alumni of FMH with a focus on promoting research, academic development, and evidence-based learning. It is my pleasure to welcome you all to the first Journal Club of the year. Today, we will be discussing an important study published in the Lancet titled as Strategies to Reduce Antimicrobial Resistance in Newborns in Low-Income Countries and Middle-Income Countries, which is mainly a systematic review and meta-analysis. Today's paper will be presented in two segments. The first segment will be covered by Areesha, Yasir, and Fatima Ahmed, both of which who are from second year MBBS, and the second half of the segment will be covered by our distinguished guest speaker, Professor Dr. Farhan Rasheed, who is a Professor of Pathology at Ameer-ud-Din Medical College. At the end of the session, we will have a question and answer session, so I encourage everyone to note down their questions and thoughts throughout the session. And with that, I would like to warmly welcome you all again. Over to you, Areesha.
Assalamu alaikum everyone. Is my screen visible to all of you?
Yes, it is visible.
So good evening everyone, and thank you so much for joining our journal club today. My name is Areesha Yasir and I'm here with my co-presenter Fatima.
Assalamu alaikum everyone. I'm Fatima and today we'll be taking you through a systemic review and meta-analysis published in Lancet Global Health in 2026 titled Strategies to Reduce Antimicrobial Resistance in Newborns in Low and Middle Income Countries. It's by Rachel Leahem and colleagues, and it looks at what actually works when we try to fight antimicrobial resistance, or AMR for short, in newborn care in resource-limited settings.
Okay, so we will take you through the background, the methodology, and the key findings, and then wrap up with the clinical implications and where the evidence still falls short. So Fatima will start us off with why this topic matters.
So let's set the stage. AMR is projected to directly cause 1.91 million deaths by 2050 and be associated with a staggering 8.22 million deaths globally. And honestly, to put that into perspective, that's like larger than the population of many countries dying either directly from or with drug-resistant infections. And this isn't just a health crisis, it is also an economic crisis. So now, why should we, as people entrusted in newborn care, specifically care about this?
So here is where it gets specific to our population of interest, the most vulnerable patient. Almost 214,000 newborns die yearly from AMR-related sepsis. Low-middle income countries carry the greatest burden. Newborns are highly vulnerable because they do not have developed immunity. They are dependent on invasive devices like central lines, ventilators, or some of them often require surgical care as well. And on top of that, antibiotics are the most prescribed NICU drug. So you have a population that is highly susceptible to infections and simultaneously is exposed to large doses of antibiotics. And here's the gap that is covered in this paper, that no prior evidence synthesis existed for newborn-specific AMR strategies. With that context, let's look at what the study actually set out to do. Fatima will walk us through the objectives.
So the study had three main goals. First, the core goal, to evaluate how effective different strategies are at mitigating AMR. Then second was the impact assessment. They wanted to measure the real clinical outcomes. It could be like the neonatal mortality, sepsis rates, colonization, etc. And then third was they wanted implementation insights, which just means that they wanted to see beyond does it work, but they wanted to understand the why behind it. So this is like the what and why. And now Areesha will walk us through the how, the methodology.
So let's talk about the methodologies. This was a rigorous systemic review. The team searched 5 major databases plus gray literature covering studies from January 2000 to November 2025 without any language restriction, which made this project globally big. It included various study types like RCTs, quasi-experimental, observational, and implementation studies. Independent duplicate screening was done by 2 reviewers, and quality assessment was done by standard tools like ROB2 and ROBINS1 for random effect meta-analysis. And when you get to the numbers, the yield is that there were a total of 4,106 relevant records, out of which 3,688 were streamed, 31 studies reviewed, and 17 were meta-analyzed. So now, before we get into the results, it is worth understanding how the authors categorize these interventions because the framework is really the backbone of the whole paper.
Right. So the authors grouped every intervention into three main buckets. First was the regulation. Now, these are like the structural and system level actions that basically create the enabling environment. This could seem like audits, surveillance, guideline developments, etc. Then the second group was education. Now, this is about training healthcare workers on AMR prevention and control. And in practice, this mostly took the form of training sessions or a journal club like this one. And then third was optimization. And this is the antimicrobial stewardship in the day-to-day sense. So basically restricting the broad spectrum antibiotic use or shortening the treatment courses, etc. And it is also worth noting that these categories are not independent, rather they're very much interdependent. And this interdependence is quite literally the whole story of this paper's main finding. Over to Areesha.
Okay, so this is the graph which we took from the article, and it shows all the details of the previously summarized slide. Now, let's move on to the partial strategies fall short. This is really the central tension of the paper. When you look at these set strategies in isolation, they each help with something, but not with the outcome that matters the most, that is mortality. So the regulation alone, which is the structural policy level intervention, it helped us cut the antibiotic use, but again, not the mortality. Then we come to optimization alone, which is the stewardship type intervention. It reduced cultural positive sepsis by 32%, but not mortality. And here's the part that really stood out to us. Even when you combine regulation and optimization, they still showed no mortality benefit. So how does it work? Let's see. Over to you, Fatima.
Now, this is quite literally the headline finding of the paper, which is that when you combine all three, meaning the regulation, the education, and the optimization together, that's when you really start to see the real or statistically significant improvements across the board. So neonatal mortality dropped by 27%, MDR infection or colonization dropped by 29%, the number of newborns being put on antibiotics at all dropped by 29% again, and perhaps the most strikingly, prolonged antibiotic courses, which were lasting for more than 5 days, dropped by 64%. So essentially, we can't just tighten the antibiotic tap and hope for the best. We really need the structural policies, the staff training, and the bedside stewardship all working together for this effect to actually be translated into something beneficial. So now let's look a bit more granular because not every pathogen or outcome responded in the same way. Areesha?
So as Fatma told us that not every outcome moved the same way, let's talk about the pathogen-specific effects and unresolved outcomes. So, on a positive note, the bloodstream isolates of Candida dropped by 85%, Pseudomonas by 75%, and Klebsiella dropped 32%. But necrotizing enterocolitis, late onset sepsis, pneumonia, MRSARS, and hospital stay length did not significantly improve. And interestingly, coagulative negative staph isolates actually doubled. A reminder that stewardship does not suppress every organism uniformly. So the effect wasn't perfectly consistent across every study. Now we will talk about how the authors handled it.
So because the meta-analysis wasn't always possible, the authors basically did something that we call the effect direction plot, which doesn't tell you statistically about the significance or the size of the effect. Rather, it more so tells you about the trend. And what's reassuring is that the direction of the effect always stayed positive, even without the statistical significance. So the neonatal mortality actually improved in 73% of the studies. The nosocomial PSI mortality improved in 100% of the studies, and the drug-resistant infections improved in 100% of the studies again.
Okay, so let's talk about the barriers and facilitators to implementation barriers. So this section of the paper is arguably just as important as the outcomes data because it tells us why things succeeded or failed on the ground. On the barrier side, delayed culture results were a huge issue. Some facilities reported turnaround times of 2 to 3 days or longer, which forces clinicians to prescribe empirically rather than based on the actual data. Understaffing in overcrowded wards were very common. Poor adherence to the infection control practices was reported repeatedly, and there was a pattern of fear-driven overprescribing, clinicians treating just in case. Now, let's talk about the facilitators. What actually helped is the locally tailored protocols, audit with feedback, and strong leadership with no added workload. This is the figure that shows the details of barriers and facilitators. This figure has been taken out from the actual article, and it has the details of all the things that are summarized in our previous slide. Now, as we know that no study is perfect, let's be transparent about the limitations.
So, just like every study, this one also has its own limitations as well as its evidence gaps. So, if we talk about the limitations of the evidence, there was high heterogeneity between the studies, and there were actually very few high quality RCTs. And what's amusing is that 94% of these were actually from tertiary level facilities, and very minimal data actually came from the low income countries. So mostly because most of the newborns were actually in primary care settings or community driven healthcare centers, but there's very minimal data from those. And the low income country was actually only in one of the studies, and all of the other ones were middle income or low middle income countries. And then, if we talk about the evidence gaps that the authors themselves identified, again, there were no community based studies, there were no primary care level studies, and wash and vaccination strategies still remained unexplored, and there was very limited multi site data. So, to pull all of this together, what should we as clinicians actually take away from this?
So, the single biggest takeaway is that antibiotic control alone isn't enough. If your hospital only focuses on restricting antibiotics without the education and system level regulation pieces, you are unlikely to see a mortality benefit. Antibiotic control alone isn't enough. Regulation plus education plus optimization together can cut mortality and resistant infections. Then, microbiology lab capacity is the key bottleneck. And at last, multi-component stewardship should become standard in low-middle income countries in newborn care.
And
So,
ultimately, the authors argue that the multi component stewardship hitting all three pillars should become the standard of the care in LMICs and specifically the newborn units, not on the aspirational extras. And to wrap up, this is the first review of its kind to really address this issue and argue that the this evidence specifically for newborn and LMICs is lacking, and they presented forward with that. And it gives a very clear and practical message that we should not just treat antibiotic stewardship as a standalone policy, rather it has to be integrated at a broader level to actually bring about survival benefit.
so thank you so much for listening. We are happy to now open the discussion.
Thank you so much, Areesha and Fatima, for presenting this important study and sharing such valuable insights with us. Now, I would like to welcome Professor Dr. Farhan Rasheed, who is a professor of pathology at the Ameer-ud-Din Medical College, with 85 publications in national and international journals, along with experience as a peer reviewer for Elsevier and BMC infectious diseases. Professor Dr. Farhan Rasheed brings extensive experience in research and evidence-based medicine, and we are very fortunate to have him with us today to guide us in interpreting and critically appraising the evidence.
Uh,
Sir, am I audible to you?
yes, thank you very much, both of the Fatmas. Thank you very much, and Areesha. And
Thank you, sir.
I would like to know audience हमारे किस ईयर से हैं. Like I want to understand कि level of understanding of research किस ईयर से हैं हमारे जो audience अब तक मेरे ख्याल है कितने 19 में ज्वाइन किया हुआ. How many audience have joined?
So we have students.
अच्छा. Anyways, चलें. Uh, Fatma and Areesha has presented. Am I clear? मेरी आवाज clear है?
Yes, sir, it's clear.
Okay. Fatima and Areesha has presented this beautiful paper. इसमें दो components हैं basically जो मैं discuss करना चाहूँगा. एक तो one is the basic core subject of the microbiology related with the microbiology, the antimicrobial resistance and उसकी control की जो उन्होंने strategies को discuss किया हुआ है. अब एंटी माइक्रोबियल रेजिस्टेंस जो है वो एज वी ऑल नो दैट इट इज गेटिंग bigger problem day by day, and every year the deaths claimed by the antimicrobial resistance are being increasing, and it is being claimed that in 2050 it will be causing more than 1 million deaths per year worldwide. So it is a huge problem, and the problem is that the low middle income countries like us, like Pakistan and the surrounding our neighboring countries, they become a source for spread of the antimicrobial resistance, because the microbes, they do not follow the geographical boundaries. Its example is XDR Salmonella typhi. It was first discovered in 2018 from Hyderabad, Sindh, and it traveled throughout the world. Like a few months after discovery of XDR typhoid from Hyderabad, Sindh, it was being discovered in a female from England, UK, and when the history was traced, then it came to know that that was a Pakistani female who was resident in UK, and she traveled to Karachi to visit her family, and from there she got XDR typhoid, and then it took it to UK. So just I am narrating this, that the antimicrobial resistance, they do not follow the geographical boundary, that if any antimicrobial resistance is occurring or is developing in Pakistan, it is not necessary that it will remain inside the geographical boundaries of Pakistan or any else country. So the developed countries, they see it that the root cause for antimicrobial resistance are the reason is being held in the low middle income countries or in low income countries. So they uh, they have developed their systems, but they put different funds and their effort to reduce the spread of these MDR and XDR bugs from the third world countries to the developed world. So now, if you see, coming back on this paper, there are different strategies which were being discussed in the literature, and there are these literature have been systemically reviewed, and the meta-analysis has been done, and the most of the studies are being conducted in the lower middle income countries. Just one study was conducted in the low income countries. So the main emphasis was how to control this antimicrobial resistance AMR in the low middle income countries. So there were three strategies, as Fatima and Areesha has described this paper: regulation, education, and optimization. These were the three main pillars of the strategies to reduce the antimicrobial resistance, and the conclusion was that by combining, not any one alone can reduce the antimicrobial resistance, but combination of all the three these strategies can reduce the antimicrobial resistance, development of the antimicrobial resistance. One interesting finding was that when the organism profile was discussed by Fatima, I think Fatima discussed the organism profile. Uh, Candida was one of the organisms which was being reduced, and the Pseudomonas and Klebsiella. These were the three organisms were being reduced by implementing these three strategies, including regulation, education, and optimization. So, if as a microbiologist, as a microbiology expert, I see that the Candida, Pseudomonas, and Klebsiella, these are the three organisms which are among those organisms among the list of those organisms which are responsible for mainly for the hospital acquired infections. So The meaning of this is that when they employed these three strategies, regulation, education, and optimization, they reduce the burden of the hospital acquired infections, because these organisms are mainly responsible for the hospital acquired infection. And at the same time, the finding was that the organisms which were coming from, most of them were coming from the community acquired infections. They were their incidence or their antimicrobial resistance was not being any affected. They have the same kind of impact, and they have more or less same antimicrobial resistance. So the catch here is that the antimicrobial resistance is being initiated, is being ignited from the hospital environment, especially in the low middle income countries, where infection control practices are not being followed, or were not being implemented because of the lack of the resources. So the hospital environment, because of the poor infection control practices, poor infection control policies, poor infection control implementation, the organisms residing inside the hospital environment, they become resistant to the antibiotics, and as well as they they transmit these organisms to the other individuals. I mean to say that the people visiting the hospital, they acquire these multi-drug resistant organisms infection from the hospital environment. And this has been proven by the analysis of these studies, that mainly the organism which is being reduced by the implementation of these policies were the Candida, Pseudomonas, and Klebsiella, and all three of them are included in the list of the hospital-acquired infections. One thing I want to this was about the microbiology or the subject details of this article, and another thing I wanted to discuss about the research design and the research impact of this study. If we see the name of the authors, uh, these authors are from different countries, but one author is Professor Zulfikar Ali Bhutta. Anyone knows who is Professor Zulfikar Ali Bhutta? किसी को पता है प्रोफेसर जुल्फिकार अली भुट्टा कौन है? He is a Pakistani, by the way. So we have a conference a day before yesterday at Ameer-ud-Din Medical College, MCOR, and Professor Zulfikar Ali Bhutta was a guest speaker over there. He is a public health expert, and he works in the field of pediatrics, and he has gained his basic qualification in Pakistan, and then from different countries of the world. He is a pediatrician, and then he has done PhD in public health. So he is a public health expert working on the pediatrics and pediatric problems, and he is currently residing in Canada. Is working as a public health expert in Canada. So the meaning, what I want to convey is that Professor Zulfikar Ali Bhutta is a public health expert, and he has done a tremendous job when we review this article and the research methodology. Basically, they have combined two methodologies: systemic review and meta-analysis. Meta-analysis and systemic reviews are two the main research designs by which you can review the data of different studies already conducted. Can anyone tell me the difference between the systemic review and meta-analysis? किसी को आइडिया है कि सिस्टेमिक रिव्यू और मेटा एनालिसिस में क्या फर्क होता है? और इस स्टडी के अंदर उन्होंने दोनों कंबाइन किए हैं. इंटरेस्टिंग चीज इसके अंदर ये है. अच्छा, अब अगर if no one can answer, then I would have to answer it. I will try to explain it in easy words. सिस्टेमिक रिव्यू और मेटा एनालिसिस के दरमियान फ़र्क क्या होता है? वंस यू डू अ स्टडी, कोई भी आप स्टडी करते हैं, क्रॉस सेक्शनल स्टडी करते हैं, तो क्रॉस सेक्शनल सिंपल स्टडीज, क्रॉस सेक्शन स्टडीज आर द सिंपल स्टडीज। तो क्रॉस सेक्शनल स्टडीज के अंदर आप क्या करते हैं, सिंगल पॉइंट ऑफ टाइम के ऊपर आप कोई भी एक ऑब्जर्वेशन को रिकॉर्ड करते हैं। लाइक फॉर एग्जांपल इफ यू से के 2026 के पहले फर्स्ट 6 मंथ्स के अंदर पाकिस्तान के अंदर हेपेटाइटिस सी की प्रेवलेंस जो है वो इतनी थी, XYZ इतनी थी, ठीक है। अब ये दिस इज अ सिंपल क्रॉस सेक्शनल स्टडी कि आपने एक पॉइंट ऑफ टाइम के ऊपर एक सिंपल एक फाइंडिंग को जो है वो पिक कर लिए, दिस इज अ सिंपल क्रॉस सेक्शनल स्टडी। अब now when we go for the systemic review, what we do is that we take different cross sectional studies and we take their findings, ठीक है। आपने 10, 20, 50, 100 जो है वो क्रॉस सेक्शनल स्टडीज या उससे एक टॉपिक के ऊपर जो आपने स्पेसिफाई कर लिया, लाइक इन दिस स्टडी द टॉपिक वाज द स्ट्रेटजीज टू रिड्यूस द एंटीमाइक्रोबियल रेजिस्टेंस इन न्यूबॉर्न इन लो मिडिल इनकम कंट्रीज, ठीक है। दिस इज द टॉपिक। इसके ऊपर जितनी स्टडीज आपको मिलेंगी उनका आप रिजल्ट्स को एनालाइज करेंगे, रिजल्ट्स को लेंगे और रिजल्ट को एनालाइज करके उनका कंपैरिजन करेंगे। इसमें जिस तरह हमने देखा था कि कितनी स्टडीज थी, देयर वर अराउंड 4106, these were the studies which were screened, और जिसमें से 31 स्टडीज जो है वो सिस्टेमिक रिव्यू में इंक्लूड हुई थी और 17 स्टडीज जो है वो मेटा एनालिसिस में इंक्लूड की। उन्होंने डाटा सर्च किया तकरीबन 4000 स्टडीज़ का, पेपर्स का, और उसके बाद उन्होंने उसको अपने क्राइटेरिया के मुताबिक, इंक्लूजन क्राइटेरिया के मुताबिक, इंक्लूजन एंड एक्सक्लूजन क्राइटेरिया को फॉलो करते हुए 31 स्टडीज़ को उन्होंने इंक्लूड किया, ऑथर्स ने इंक्लूड किया सिस्टेमिक रिव्यू में, और 17 स्टडीज़ को इंक्लूड किया जो उनके क्राइटेरिया मैच हुआ तो उनको मेटा एनालिसिस में। तो सिस्टेमिक रिव्यू के अंदर उन्होंने क्या किया कि उनके रिजल्ट्स को लेके रिजल्ट्स को कंपेयर किया, रिजल्ट्स को एनालाइज किया है, और लाइक फॉर एग्जांपल उन्होंने कहा जी कि 30% स्टडीज़ के अंदर जो है वो ये फाइंडिंग उनको मिली, उसमें सूडोमोनास मिला। फॉर एग्जांपल 37 में जो है वो कैंडिडा की जो है वो फ्रिक्वेंसी कम हो गई। सो दिस इज व्हाट दे हैव टेकन अप द रिजल्ट्स फ्रॉम द स्टडीज एंड देन डिड द statistical analysis by applying on the results, ठीक है। This is one thing. The second thing is what is meta-analysis and what is the difference between the meta-analysis and the systemic review. Meta-analysis में क्या होता है कि आप raw data ले लेते हैं, ठीक है। Systemic review में आपने क्या किया, आपने results जो है उनके जो उन्होंने पब्लिश कर दिए उन रिजल्ट्स को उठा के आपने उनका आपस में जो 17 या 31 स्टडीज जिस तरह इस पेपर के अंदर है उनका जो है वो एक स्टैटिस्टिकल एनालिसिस कर लिया है। और जो मेटा एनालिसिस है, मेटा एनालिसिस में आप क्या करते हैं कि आप उन सब का रॉ डेटा, मेटा एनालिसिस इज मोर एक्सटेंसिव देन एज कम्पेयर टू सिस्टेमिक रिव्यू। उसमें आप क्या करते हैं, आप उनके रिजल्ट्स नहीं लेते, रिजल्ट्स की बजाय आप क्या करते हैं, आप उनका रॉ डाटा लेते हैं। रॉ डाटा लेके लाइक उन्होंने इफ दे से कि जी वी विजिटेड 2 hospitals, for example, one study says that we visited 2 hospitals and we recorded the data of 200 patients. दूसरी स्टडी ने कहा जी हमने 150 पेशेंट्स का डाटा रिकॉर्ड किया। तो अब वो क्या करेंगे और उसका साथ उन्होंने टेबल बना दिया। तो मेटा एनालिसिस के क्या में आप क्या करेंगे, आप वो 200 पेशेंट्स का डाटा पिक कर लेंगे वहाँ से, इसी तरह उसको कंबाइन करेंगे 150 पेशेंट्स का जो डाटा है दूसरी स्टडी में से उसको कंबाइन करेंगे, और एट द एंड ऑफ द लिस्ट आपके पास तमाम, फॉर एग्जांपल अगर जिस तरह स्टडी में 17 स्टडीज थी तो यू विल हैव डाटा ऑफ 3000 और 4000 और 5000 जितने भी टोटल उसके नंबर पे उन सब का डाटा इकट्ठा आ जाएगा और आप उसको फिर री एनालाइज करेंगे। So this is the main difference between the meta-analysis and the systemic review, that in systemic review you take the results and then you analyze them, but in meta-analysis you take the raw data from the selected studies. This is the main difference. So a meta-analysis is a bit difficult and it requires more extensive statistical analysis, and even that, for that matter, you need more sophisticated statistical tools for that matter. So I hope I have covered both aspects, the microbiology aspect of this study, and I have tried to explain the scientific basis or research basis of this study. So I think if anyone have questions, it is more than welcome now.
Sure. Thank you so much, Dr. Farhan, for taking the time to answer for sharing your valuable insights. We will now like to invite all of you to share your questions and queries regarding the topic we discussed. The chat box is present right at the bottom of your screens. Dr. Farhan will be taking your questions and sharing his insights and perspectives with us. For those of you who cannot find the chat box, it is present right at the bottom of your screen.
Yeah, Fatma Ahmed, the question is, since in low income countries have many primary care centers in the rural areas that might not be able to implement all three components of the framework recommended. So if they could only choose one, which one should they work first? So if by looking at this study, Fatma, uh, इसका थोड़ी सी अगर हम इसके बैकग्राउंड में जाएं कि जो इस स्टडी की लिमिटेशन है, और उसने खुद मेंशन किया है कि हमने जो ये मोस्ट ऑफ द स्टडीज़ हैं, दे हैव बीन कंडक्टेड एट द टर्शरी केयर हॉस्पिटल्स. अच्छा, अब उसका बैकग्राउंड क्या है और उसकी रीज़न क्या है कि टर्शरी केयर सेंटर्स के अंदर क्यों ये स्टडीज़ कंडक्ट की हुई हैं. उसकी वजह ये है कि जो थर्ड वर्ल्ड या लो मिडल इनकम कंट्रीज़ हैं, वहाँ पे प्राइमरी हेल्थ केयर का सिस्टम इतना स्ट्रॉन्ग नहीं है, and they are not connected with the tertiary care hospitals, and they are not connected with the different study centers या university hospitals जहाँ से ये researches conduct हो रही होती हैं. So basically there is a disconnect between the primary health care and these research centers. One reason in my opinion is that they are disconnected. And regarding, coming back to your question, Fatma, then the which component of these should be implemented. uh, I think that education is one of the most important component which can play a role, but you need to do some of the studies at the primary level, because as you have seen in this meta-analysis, that the regulation, education, and optimization, these were the three strategies, but they collectively played a significant role as compared to their individual role. So we can have a study at the primary healthcare level in the low middle income countries to produce an evidence, but in my opinion education can play a very important role. Hope to answer your question, Fatma.
Yes, thank you so much, sir. That makes a lot of sense.
And any other question, please? No questions? So we have another question, Abdullah Suhail. The study was successful in targeting Candida, Pseudomonas, and Klebsiella. Sir, as we know that E. coli, Acinetobacter, and other organisms cause neonatal disease as well as and are developing resistance. What are some strategies that we can implement in hospital in Lahore to address this gap? अच्छा, इसमें अब्दुल्ला, I think that they have narrated the topmost organism which have been reduced their antimicrobial resistance. Otherwise, there is no deficiency of antimicrobial resistance among these three organisms: Candida, Pseudomonas और Klebsiella. कैंडिडा, सुडोमोनास और क्लैप्सियाला ये भी किसी तरह एंटी माइक्रोबियल रेजिस्टेंस के अंदर किसी तरह काम नहीं है, क्योंकि वी आर रिपोर्टिंग एंड वी आर seeing the MDR and pan drug resistant Pseudomonas, pan drug resistant Klebsiella, and Candida, a new species of Candida auris has been reported from low middle income countries. Even it has been reported from Pakistan, and Candida auris is one of those Candida species which is resistant to almost all anti fungal drugs except one. So if we say that the E. coli, Acinetobacter, and other organisms are causing neonatal disease, but these Candida, Pseudomonas, and Klebsiella, they are also causing, because they are hospital acquired organism. They are hospital acquired organism, and they are also causing the neonatal sepsis in the neonates acquired by the hospital. So we cannot say that these are not the actual cause of the neonatal sepsis. And regarding the second part of your question, what are the some strategies that we can implement in hospital in Lahore to address this gap? The main thing which I mentioned earlier is the infection control practices implementation and infection control strategies. बिकॉज ये सारे नाम जो स्टडी में भी हैं, जो अब्दुल्ला आपने भी ली हैं, ये तमाम के तमाम दे आर मेनली रिस्पॉन्सिबल टू बी स्प्रेड फ्रॉम द हॉस्पिटल एक्वायर्ड इन्फेक्शन में रिस्पॉन्सिबल है। और हॉस्पिटल एक्वायर्ड इन्फेक्शन को रोकने के लिए इन्फेक्शन कंट्रोल प्रैक्टिसेस बहुत इंपॉर्टेंट रोल प्ले करती हैं। उसमें आप इन्फेक्शन कंट्रोल प्रैक्टिसेस के अंदर आपकी पॉलिसीज भी आ जाती हैं, आपकी एजुकेशन भी आ जाती है, और फिर आगे फिर ऑब्वियसली नेक्स्ट स्टेप के अंदर आपकी ऑप्टिमाइजेशन भी आ जाती है। तो सो द बेसिक्स इज द बेसिक नॉलेज ऑफ इन्फेक्शन कंट्रोल प्रैक्टिसेस एंड देन द इम्प्लीमेंटेशन। पॉलिसीज और रेगुलेशन इस तरह की होनी चाहिए कि वो इन्फेक्शन कंट्रोल प्रैक्टिसेस को आप इम्प्लीमेंट कर सकें टू स्टॉप दीज ऑर्गेनिजम्स। Hope to answer your question, Abdullah.
Sir, we have one more question that says that effect direction plots ignore magnitude and statistical significance doesn't risk this overstating. How consistent the evidence really is for that?
Sorry, I didn't get your question.
The question is that effect direction plots ignore magnitude and statistical significance. Doesn't this risk the overstating how consistent the evidence really is?
Sorry, the sound was not clear. Can you type the question? Sound was not clear.
Sure. Sir, the questions have been posted. I think they may be visible on your screen as well.
Sorry, not getting the question. Some distortion
If
is
you don't mind, I can read out the question for you. So, the question is that the effect direction plots ignore magnitude.
Sorry, I didn't. There is distortion.
Sir, the question is written in the chat box. In the question box, we do have that question.
Okay. Let me read it from the chat box. I cannot see any question in the chat box besides the Abdullah Sohail question.
Sir, the question is in the question and answer box. I can read it out for you.
Please.
So, one of the questions is that the effect direction plots ignore magnitude and statistical significance. So, doesn't this risk overstating how consistent the evidence really is?
Yes, एक्चुअली जब उसकी स्टडी को जब आप कर रहे हैं और उसमें उसकी स्टैटिस्टिकल वैल्यू सिग्निफिकेंट नहीं आ रही, तो आप उसको स्टैटिस्टिकली प्रूव करना बड़ा मुश्किल हो जाता है उसको। और आपकी स्टैटिस्टिक्स जो है वो जब तक आप एविडेंस की आप बात करते हैं, तो जब तक स्टैटिस्टिकली आप उसके ऊपर उसका स्टैटिस्टिकल एनालिसिस नहीं लगाते और उसको स्टैटिस्टिकली सिग्निफिकेंट प्रूव नहीं करते, उस वक्त तक आपकी वो एविडेंस क्रिएट नहीं होती।
Okay, got it, sir. There's another question. I think it's a bit relevant to the ones that were asked previously as well. That are there any Pakistan-specific recommendations from your side about antimicrobial resistance?
There are national guidelines about infection control practices, and National Institute of Health has published these guidelines officially from their platform, and these are guidelines which should be implemented in the hospital, which should be followed by the clinician practicing. And the main gap is that we do not follow these guidelines, and we do not implement those guidelines. So that is the main gap. Otherwise, there are national guidelines available regarding the infection control practices and their implementation in hospitals. And But the one thing that what I feel is that those guidelines are just guidelines, and they will be implemented when there will be a regulator stress or regulator compulsion. Like for example, if government says that this has to be done in hospital, and it will be monitored by the government, then it will be implemented. Otherwise, that guideline will stay in the book. That guideline will stay in the guidelines only, but it will not be implemented जब तक कि गवर्नमेंट उसके ऊपर एज ए कानून एज ए लॉ उसको इम्प्लीमेंट नहीं कराती, उस वक्त तक नहीं होता ये. दिस इज व्हाट वी आर सीइंग in the form of healthcare commission. Healthcare commission is a regulatory institution by the government, and they have set up different standards, and they get those standards being implemented by the law. If someone is not following those standards, the healthcare commission has the authority to fine those healthcare hospitals and healthcare settings. So the summary of this point is that there are guidelines available in Pakistan, but implementation is poor because of lack of the legislation or regulator laws. Everything is available in the guidelines.
All right. Understood, sir. And there's actually another question that is a bit relevant, and that is that what strategies can we implement in hospitals to reduce the incidence of nosocomial infection specifically? And how much of a role does the patient load play in the spread of these infections?
Very good question and very pertinent question. And like one major thing, if we talk of the how to reduce the nosocomial infection, is the most important thing is the hand washing. Hand washing and hand hygiene is one of the most important thing which can reduce the burden of the nosocomial infection. And if we talk of the public sector hospitals, which are already overburdened, and hand hygiene is not being monitored by the hospital authorities so much. So the hand hygiene is one of the most important reason for nosocomial infections, which can lead to spread of the nosocomial infection. And the second part of your question was the how the overcrowding is playing a role. So I think overcrowding is one of the biggest reason of the nosocomial infection. Like for example, if you see the patient, if any one of you have happened to go to the government hospital, the public sector hospitals emergencies, there are hundreds of patients lying side by side, and one of them is coming with the high blood pressure, and second one is coming with the coughing and sneezing and respiratory symptoms. So the patient coming with with non-communicable disease, he or she is getting communicable disease from the hospital because of the overcrowding. So overcrowding is one of the very important reason of the nosocomial infections.
All right, sir, got it. And there's actually a slightly other question that is by someone who wants to join public health sciences. और वो पूछना चाह रहे हैं कि foreign countries में अगर public health sciences join करना तो which research topics should they focus on?
Public health, public health is a very big domain. So, if talking about the low middle income countries and of obviously like Pakistan, what I feel is systems design, healthcare systems design is part of the public health subject. Public health is a very big subject. So, uh, जो आपके हेल्थ केयर के सिस्टम्स को डिज़ाइन करना है और उनकी इम्प्लीमेंटेशन है, ये एक ऐसी चीज़ है जिसके ऊपर थर्ड वर्ल्ड कंट्रीज़ के अंदर और उसके अंदर बहुत ज़्यादा काम हो भी रहा है और उसके ऊपर काम करने की ज़रूरत है. लाइक एक और चीज़ जिस तरह one of my friend was working in I think in Germany in public health. He was working on the economics of the healthcare systems and like that. सो इन माई ओपिनियन इकोनॉमिक्स और वो सारी चीज़ें हमारे लो मिडिल इनकम कंट्रीज़ में बाद में आती हैं. हमारे यहाँ तो सबसे बड़ा प्रॉब्लम ये है कि हमारे हेल्थ केयर सिस्टम्स के डिज़ाइन ही ठीक नहीं है. आपने अपने हेल्थ केयर सिस्टम को डिज़ाइन किस तरह करना है, आपका प्राइमरी हेल्थ केयर सिस्टम एग्जिस्ट ही नहीं करता. प्राइमरी सेकेंडरी और टर्शरी लेवल के जो हेल्थ केयर सिस्टम्स हैं, आपका तमाम का तमाम बर्डन जो है वो टर्शरी केयर हेल्थ केयर सिस्टम के ऊपर है. प्राइमरी और सेकेंडरी तो ना होने के बराबर हैं और मतलब जो एग्जिस्ट भी करते हैं तो वो आपका उस तरह पेशेंट केयर या पेशेंट बर्डन को कैटर ही नहीं करते. तो देर इज़ बेसिक फ्लॉ इन द स्ट्रेटजीज एंड इन द हेल्थ केयर सिस्टम डिज़ाइनिंग. तो policy making and the designing of the healthcare system is a very big thing in low middle income countries और इसके ऊपर काम करने की बहुत ज़रूरत है.
Got it, sir. Thank you so much. And I think these are actually all of the questions. You have answered all of them. So, Fatima, if you're here, over to you.
Thank you so much, Dr. Farhan, for taking the time to answer our questions and for enriching today's session with such valuable insights and your expertise in the field. It has truly been an honor and a privilege to have you with us today. I hope today's Journal Club session has given us all a deeper understanding of how antimicrobial resistance in newborns works, the factors contributing to its growing burden, and most importantly, the strategies that can help us address this challenge, particularly in low and middle income countries like Pakistan. With that, I would like to formally conclude this today's Journal Club session. Thank you all for joining us again and for being an engaged part of this session.
Thank you very
We'll
much.
now be ending the meeting. Any last words from you, sir?
Sorry.
Would you like to say something?
Thank you very much for inviting me today, and it was pleasure to have you all on this forum. And to me, it was a very joyful experience because you all are, I think, undergraduate. None of you are the graduate, and you are all are undergraduate students of MBBS, and the enthusiasm from the students is very good for the research and for the future planning. And wish you all of the best. And if you need any kind of session again, do reach out, and I am always available for you. Thank you very much. It was a pleasure to have you all.
So much, sir. It was also a pleasure to have you here with us as our guest speaker. Thank you so much, everyone. And Areesha, I think we will be ending the meeting today. Allah
Thank
Hafiz.
you. Allah Hafiz.